So our next speaker, before we move into our discussion, I think is known to all of you, Lee SWANSTROM. He said I could title him however I wanted, which is a dangerous invitation. So let's see. Lifetime Achievement Award. He said it's his mid-career achievement award, actually, because lifetime sounds too old. Past president of SAGES, past president of Fellowship Council. Interestingly, he's also presently advising the Ministry of Health of how to revamp training in France, and spends about half of his time doing that as well. So I think Lee has really a wealth of experience and a breadth of perspective that will sort of bring this all together to think about from the, how we might, as a Fellowship Council, think about integrating all of these things that we've heard about as we move forward.
Thank you very much, Rebecca. A little bit of what you're going to hear is a little bit redundant, especially if you went to Frank Lewis's talk, and I apologize for that part, but this is a lot to get your head around. It's got a lot of players involved in it, and I think it doesn't hurt to hear this again and again. I think it took Joe and I a couple years to even start understanding how the pieces of this puzzle work. I'm going to do something a little bit different, and like I often do, something a little bit slightly outrageous, because I'm going to do a what if. Because I think it's important for the strategic planning of the Fellowship Council to conceive of what if all this does happen, what if residency training does change, and I'm certainly not saying it is, but what if 4+1 plus 4+1 or 4+1, 2, 3 really happens, what should the Fellowship Council start doing at this point to prepare for that possible future? My disclosure slide is very similar to Joe's and Frank Lewis's. I'm a board director, but these are purely my opinions and not any official statement from the board. And just to remind you, things didn't change for a long, long, long time. I think many in the room really grew up under the Hallstedian purview, except until 1980. And then a lot of stressors started happening to surgery, and surgery did change quite, surgery residency changed quite a bit in the 80s because of decreased changes in funding, waning interest in surgical careers, increasing supervision rules, all those things you heard about in Dr. Lewis's talk today really served to almost like metamorphic rock change how residency happened. And I think the majority of people feel there wasn't a really beneficial change to residents. I think that's a little overstating that those things specifically did it. Time changed, surgery itself changed, but whatever. We were left with a somewhat compromised system. This has been obvious to everybody. You know, there's been blue ribbon committees getting it. You've heard this kind of mantra of fix the five, something's wrong with our 5-year surgical training, Hallstedian training scenario for years and years and years. Really, I think many were getting frustrated because not a lot was really happening. It didn't change over the last decade since we started talking about all this, or even from the 80s when this happened. But I think we're starting to see, I think everybody's kind of abandoned the fix the five paradigm because they tried to mentally work it through and it just never happened. And now kind of the hot topic, the hot concept, which may or may not happen, is this 4+1, 2, or 3. This new thing of pushing training and concentrating it into earlier, maybe using different training techniques, technology to do it, but to make residents board eligible at the end of their 4th year and requiring additional 1, 2, or 3 years to obtain qualification. I won't go into this. You heard Mary's great talk about the flexibility in surgery training, and really this is progressing and this changing. I think it's a little bit of an arrow. Residency training, so I'm going to kind of break things down and kind of walk you through this rectal societies, vascular surgery, and the boards. Programs are certified not by the Board of Surgery, but programs are controlled by the ACGME and through the RRC, the police arm of the ACGME. Individuals are certified by the boards of surgery. Boards of surgery or the, with the subboards of the ABS or the other colorectal, peds, etc. So keep that paradigm in motion, because what's happening is fellowship wasn't like this, but it's gradually being moved into there. there is a precedent in fellowship training, and remember, probably 80% of general surgery residents are doing it. I think that's numbers not going down. Frank mentioned it was in the mid-70s. It's a little bit hard to tell, but that may be a seasonal fluctuation, but it's pretty clear that the vast majority of residents go into fellowship training. As you heard, 50% are ACGME boarded fellowships, or I really shouldn't say it, but colorectal, except all the ones you know, and 50% are non-ACGME fellowships. And the fellowship council programs are probably 70% of that non-ACGME program. So that's just the picture that we're looking at. So when you fit that into the paradigm, so there is already a well thought out paradigm for 50% of the fellowships that are out there, and those are the ACGME approved ones. So once again, the ACGME gets to weigh in on what the curriculum looks like, how the residents progress through it, how the fellows progress through it, and they're supervised by the specialty boards. Programs are certified by the ACGME, just like residency programs are, and individuals are certified by the boards of respective boards of surgery. So that's the paradigm for fellowship training right now for 50% of the fellowships. Some of us in the fellowship council sometimes are a little bit confused by people get a little bit concerned and upset about non-ACGME fellowships, but if you look at it this way, criteria and curricula is now designed and mandated by the specialty societies with, as Joe mentioned, nobody over them really. Programs are certified by Fellowship Council, for instance, or the specialty societies. They go and do site surveys, and I would say that right now that's in pretty good position. That the Endocrine Society does a good job with endocrine because they're specialists. It benefits their specialty. But by and large, there's nobody certifying the individual product of this. Now remember, the American Board of Surgery is there to protect the public and see its interest in by certifying high quality medical practitioners, and that really is missing from this element. So if you look at it from the public trust issue, 400 of the 800 advanced trainees per year are certified by the boards, or subject to the, certified by their boards, supervised by the ACGME, but of course they're subject to all the programs of residency training, lack of independence, 80-hour work week, all those things you just heard. The other half of the fellows that are trained graduate also from accredited programs, but the individuals are not certified. And that's really the public doesn't know when somebody says, I was a bariatric fellowship trained surgeon, exactly what that means. So as you heard, under consideration is at the Board of Surgery is recognition that postgraduate fellowship training is an essential component of general surgery training. That's not an official position yet, but that's widely discussed within the committee structure of the board. There's an offer to collaborate with specialty societies, and that's a genuine offer by the board to examine and certify non-ACGME graduates, or at least to collaborate in a process to do that because of the concern about that large number of people graduating from a fellowship that aren't certified. This might someday be official if it's allowed by the ABMS, but not allowed at this point. Or maybe just unofficial. The American Board of Surgery is one of the best psychometrics and high-stakes exams for medical professionals that's out there. And it may be a role of being consultants for that if it's not allowed by the ABMS. I think the minimum conditions that the board would set would be that all the societies participate in the certification process. They don't want to do it by themselves. They'd want the specialty societies to participate, and that the programs that are certified meet the same level of quality that's been set by the ACGME. So that the Fellowship Council approved for a program means an equal quality as ACGME approved fellowship program. So now I'll go into kind of paint you a little possibility picture so you can start discussing amongst yourselves how the Fellowship Council might get ready for this. So a possible process might be that a society, a subspecialty society, or their representative like the Fellowship Council, would make sure that all their programs that they certified met ACGME level standards. And that's going to be a little bit difficult for a group like the Fellowship Council, because one of the ACGME standards is that the fellows are board eligible. And so our FMG folks are out of luck on that. Societies would design criteria, either through their education committees or through the Fellowship Council, for eligibility to take the exam, what milestones are needed, how many cases are needed, what type of cases, what sort of curriculum to complete. The society representatives would work with the American Board of Surgery to create a test blueprint and write test questions, and the ABS would administer a certifying exam. So this is a possibility of the future if that thing really played out. So the possible picture of a new general surgery training paradigm that integrates fellowships would be 4 years of a core general surgery training, perhaps take the qualifying exam at the end of that so you're board eligible, then have a mandatory experience year. Could be a general surgery year, like a transition to practice, track specialty year, fellowship, as you've heard, possibly. Become board certified or eligible for board certification, and then do a specialty fellowship through ACGME or non-ACGME, but certified under the umbrella of the American Board of Surgery. So it has a lot of implications, as Joe mentioned. I mean, mind-boggling implications with that. You'd be talking about possibility of board exams in some form of GI surgery. What would that look like? Would it be one big global exam? Would it be a modular exam where you picked 3 or 4 modules that you picked and to get a certificate of added competency in some realm of GI surgery, bariatric, foregut, etc.? A lot of questions remain. How do the ACGME fellowships that overlap with the non-ACGME, like colorectal, fit in? Will general surgery be a fellowship specialty? Will the transition to practice fellowships and the acute care fellowships grow into full-fledged, equal fellowships? Where will be their home? Will the Fellowship Council house those? Will the American College of Surgery house those? And what do we do with all those things that are now becoming emerging specialties like abdominal wall reconstruction, etc.? Do we really need to finally throw out MIS as a concept? How about other tool-based things as opposed to disease-based things like flexible endoscopy? The reason we're all hesitant at saying this is going to happen is because it doesn't have a lot to do with the Fellowship Council. It doesn't have a lot to do with SAGES. It doesn't have a lot to do with the American Board of Surgery. There's dozens of players in this, dozens of players, the Board of Medical Specialty, the other boards of surgery, specialty societies, the other specialty societies, and not just that, but the residency training programs. The trainees themselves will have a stake in this. The hospitals and the public will all need to weigh into this process and really look at it. But I think it's pretty obvious to me as a person that this is the direction things are moving. It's probably going to have various twists as it moves along, but I think the Fellowship Council would be well, and the program directors would do well to start crafting fellowships so they fit into this kind of paradigm so it doesn't happen to you, but it happens with you. Thank you.